Every 40 seconds, someone in the United States has a heart attack. By the time you finish this video, hundreds more will have joined that number. Heart disease remains the single leading cause of death in this country, responsible for more than 600,000 lives every year. And a heart attack is very often the event that actually ends it. Here's what almost nobody explains clearly. In a large share of cases, the heart sends out real specific warning signals, sometimes hours or days before the major event, and a meaningful number of heart attacks happen with barely any of the symptoms most people are watching for at all, closer to 1 in 5 according to the CDC, quiet enough that the person having them doesn't fully register what's happening. That changes today. I'm Joshua Smith, and if plain language health information without the drama is useful to you, subscribe and hit like so more people find this. Let's start with the same reframe that matters for almost every major cardiovascular event. A heart attack is essentially never a bolt out of the blue. In the overwhelming majority of cases, it's the predictable endpoint of arteries that have been narrowing quietly for years, sometimes decades. And when something develops slowly and predictably, it can in a lot of cases be caught and interrupted before the final step happens. That's really what this video is about. There are two main patterns a heart attack can take, and it's worth knowing both. The first is a complete blockage, where a coronary artery, one of the vessels feeding the heart muscle itself, gets fully sealed off, usually by a clot that forms on top of a ruptured plaque. Doctors call this a STEMI, and it tends to produce the most classic, dramatic presentation, the kind most people picture when they think of a heart attack. The second is a partial blockage, called an NSTEMI, where blood flow is significantly reduced but not completely cut off. It's still a genuine heart attack, still causes real damage to heart muscle, and still requires urgent treatment. But because some blood is still getting through, the symptoms can be milder, come and go rather than staying constant, and get mistaken for something less serious. That's a real part of why NSTEMIs are more likely to go unrecognized in the moment, both by the person experiencing one and sometimes even on an initial evaluation, since the classic dramatic presentation people are trained to look for simply isn't always there. To understand why speed matters so much here, it helps to think about how demanding your heart muscle actually is. Unlike most of your organs, your heart never gets a break. It beats around 100,000 times a day, every day for your entire life, and it needs a constant, uninterrupted supply of oxygen-rich blood to keep doing that. That supply comes through the coronary arteries, vessels small enough that even a modest amount of narrowing can meaningfully restrict flow. When one of them gets blocked, the section of heart muscle it feeds starts to be damaged within roughly 20 to 40 minutes, and that damage becomes more extensive and less reversible the longer blood flow stays cut off. That's the entire reason cardiologists describe a heart attack the same way neurologists describe a stroke, as a race against the clock. It's not a figure of speech, it's a race to save heart muscle before it's lost for good. Here's the part most people never hear. For a coronary artery to suddenly seal shut, the groundwork usually took years. The inner walls of the vessel accumulate fatty deposits, a process called atherosclerosis. The exact same underlying process behind most strokes, just happening in the arteries that feed your heart instead of your brain. Cholesterol and other debris build up along the artery wall, a plaque forms, and the opening available for blood to pass through keeps narrowing. This is not an explosion out of nowhere. It's the last step in a long process. And along that road, your body often sends out a warning. In medicine, that warning has a name: unstable angina. Chest discomfort caused by a temporary reduction in blood flow to the heart that hasn't yet caused permanent damage. Picture a coronary artery that's already significantly narrowed by plaque. Under normal, resting conditions, enough blood might still squeeze through. But under exertion, or sometimes even at rest as the plaque becomes more unstable, blood flow briefly drops below what the heart muscle needs, and you feel a symptom, pressure, tightness, discomfort, that eases once flow improves again. Unstable angina is different from the more predictable chest tightness some people feel reliably during exercise that goes away with rest. That more predictable pattern, often called stable angina, tends to show up at roughly the same level of exertion each time and resolves quickly once you stop and rest. And while it's still worth mentioning to a doctor, it's a different clinical picture. Unstable angina tends to be new, worsening, or showing up with less and less exertion than it used to, sometimes even at rest, lasting longer than it used to, or simply feeling different or more intense than a person's usual pattern. And research consistently shows it's frequently a direct preview of a full heart attack in the near future. Anyone experiencing a new pattern like that needs same-day medical evaluation, not a wait-and-see approach. Because the window where a full heart attack can often still be prevented is exactly the period right after symptoms like this start showing up. Let's walk through 5 specific warning signs, what they actually feel like, and what's happening inside your body when they show up. The first is chest pain, pressure, tightness, or a squeezing sensation, usually centered behind the breastbone. It's worth knowing this often isn't described as sharp pain at all. A lot of people describe it more as heaviness, fullness, or someone sitting on their chest, and it typically lasts more than a few minutes, or comes and goes with increasing intensity, rather than a brief passing twinge. What's happening mechanically is that a section of heart muscle is being starved of oxygen, and the nerve signals coming from oxygen-deprived heart tissue are what your brain interprets as that pressure or tightness in your chest. This is the symptom most people expect, but it's worth taking seriously specifically because it's easy to talk yourself out of, blaming it on heartburn, stress, or a pulled muscle, when the actual driver is a genuine reduction in blood flow to your heart. The second is pain that spreads beyond the chest into one or both arms, especially the left, the jaw, the neck, the back, or sometimes the upper stomach. This happens because of something called referred pain. The nerves carrying signals from your heart share pathways in your spinal cord with nerves from these other areas. So your brain can end up interpreting heart-based pain as if it's coming from your arm or jaw instead of or alongside your chest. This is exactly why some people experience a heart attack primarily as jaw pain or arm discomfort with barely any chest sensation at all, and why that presentation gets dismissed as dental pain or a muscle strain far more often than it should. The third is shortness of breath, sometimes with chest discomfort, but notably sometimes entirely on its own. When part of the heart muscle isn't getting enough blood, the heart's pumping efficiency drops, and blood can start to back up into the vessels, feeding the lungs, making it harder to get a full, satisfying breath, even at rest or with minimal activity. Shortness of breath, as a standalone symptom without obvious chest pain, is one of the more commonly missed presentations of a heart attack, particularly in older adults. The fourth is a cluster of symptoms that often show up together: nausea, breaking out in a cold sweat, and lightheadedness, or a sense that you might pass out. These come from your autonomic nervous system reacting to what's happening in your heart, and from a real, if temporary, drop in how much blood your heart is able to pump out to the rest of your body, including your brain. This combination is easy to mistake for a stomach bug or simple dehydration, especially when it shows up without dramatic chest pain attached to it. The fifth warning sign is the one that surprises people most, because it doesn't always look like a heart attack at all. Close to 1 in 5 heart attacks are what doctors call silent, meaning the person has few or none of the classic symptoms, sometimes only recognized after the fact on an EKG or imaging done for an unrelated reason. This pattern shows up disproportionately in 2 groups worth knowing about specifically. Women often present differently than the classic pattern most people picture, more likely to report fatigue, indigestion-like discomfort, back pain, or a general sense that something is wrong, without the crushing chest pressure that dominates most public health messaging. And that mismatch between the textbook description and how women actually experience it is a real, documented reason heart attacks in women get diagnosed later than in men. And people with diabetes are also more likely to have a blunted or absent pain response during a heart attack, a consequence of nerve damage from long-term high blood sugar, called autonomic neuropathy, that can dull the pain signals a heart attack would otherwise produce, sometimes leaving fatigue or breathlessness as the only real clue something is wrong. If you fall into either of those groups, or you're caring for someone who does, it's worth treating vague symptoms like unusual fatigue, indigestion that doesn't resolve, or unexplained back or jaw discomfort with real suspicion rather than assuming a heart attack would announce itself more obviously. Now let's talk about what actually damages your coronary arteries in the first place, because a few myths here genuinely cost people time they don't have. The first major factor is LDL cholesterol, often called the bad cholesterol, which plays a more direct central role in coronary artery disease specifically than in almost any other condition. LDL particles that get into the wall of an artery can become trapped and oxidized, triggering an inflammatory response that draws in immune cells and starts building the plaque that eventually narrows the vessel. HDL, sometimes called the good cholesterol, works partly in the opposite direction, helping carry excess cholesterol back out of the artery wall toward the liver for disposal, which is part of why the ratio between the two numbers matters, not just the total. This is why cardiologists care so much about your actual LDL number, not just your total cholesterol, and why getting it checked and treated if it's elevated is one of the single most impactful things you can do for coronary health specifically. The second major factor is the same one that damages arteries throughout your body: chronically high blood sugar. Glucose needs insulin to move efficiently into the cells lining your blood vessels, and when that process is impaired, those cells become damaged and starved even while your bloodstream carries plenty of sugar, leaving behind rough, scarred patches that become prime real estate for plaque to build on. This process starts well before an official diabetes diagnosis. Even mild prediabetes is enough to quietly injure your coronary arteries over time. The third factor is smoking, which chemically damages the vessel lining with every cigarette, while simultaneously making your blood thicker and more prone to clotting. A combination that raises ischemic cardiovascular risk by roughly 2 to 4 times compared to non-smokers with similar cholesterol and blood pressure numbers. And the fourth is blood pressure, which stresses and damages vessel walls over years of chronic elevation, directly accelerating how quickly plaque builds up inside your coronary arteries. Physical inactivity and carrying excess weight, particularly around the midsection, tend to compound several of these at once, since they're commonly linked to higher blood pressure, less favorable cholesterol numbers, and reduced insulin sensitivity all at the same time, which is part of why regular movement shows up so consistently in research as protective for the heart specifically, not just for weight management in general. Age matters too, though not in the oversimplified way it usually gets discussed. Risk rises meaningfully after about age 45 for men and 55 for women, and family history plays a real independent role. A parent or sibling who had a heart attack at an unusually young age is a genuine signal worth mentioning to your own doctor, since it can shift how aggressively your own risk factors get managed. So what do you actually do if you're experiencing what feels like a heart attack right now, or you're with someone who is? Call emergency services immediately. Don't drive yourself, and don't have someone drive you if calling for transport is an option, since a heart attack can worsen suddenly and paramedics can begin treatment before you even reach a hospital. While you're waiting, sit or lie down in a comfortable position rather than continuing to move around, and loosen any tight clothing. One thing worth knowing that's genuinely different from advice you might have heard about stroke: if you're not allergic to aspirin and have no known bleeding disorder, chewing, not swallowing whole, a single regular adult aspirin while waiting for help is a widely recommended step, since chewing it gets the medication working faster and it can help limit clot formation during exactly the window that matters most. This is worth confirming with your own doctor ahead of time given your specific health history, but it's a meaningfully different rule than the blood thinner caution that applies to stroke, since the underlying problem in a heart attack is almost always a blood clot rather than a bleed. If you can, note the time your symptoms started. That detail genuinely affects treatment decisions once you reach the hospital, since some of the most effective interventions are most beneficial within the first few hours. Once you're at a hospital equipped to treat a suspected heart attack, the goal for a full blockage is usually to open that artery back up as fast as possible, either with a procedure called a percutaneous coronary intervention, where a cardiologist threads a catheter up to the blocked vessel and places a small mesh tube called a stent to hold it open, or in some cases with clot dissolving medication if a catheter lab isn't immediately available. Hospitals track how quickly they can get a blocked artery reopened as one of their core quality measures, precisely because that timing has such a direct effect on how much heart muscle ultimately survives. Once you've been through a suspected cardiac event, or a doctor is investigating symptoms like unstable angina, there are tests worth knowing about, and they generally fall into two categories. One's used in the moment, and one's used to look ahead. In the moment, an EKG, a recording of your heart's electrical activity, is usually the fastest way to identify a heart attack in progress, often within minutes of arriving at care. And it's typically one of the very first things done for anyone with suspected cardiac symptoms. Alongside that, a blood test measuring troponin, a protein released into your bloodstream when heart muscle is damaged, helps confirm the diagnosis and gives a sense of how much muscle has been affected, and is sometimes repeated a few hours later to track the trend. Looking forward, once you're past the acute event, or if you have risk factors and want a clearer picture before anything happens, 3 evaluations are worth discussing with your doctor. A coronary calcium score, a CT scan that detects and quantifies calcified plaque in your coronary arteries, giving a concrete sense of how much atherosclerosis has already built up. A detailed lipid panel, ideally including your LDL specifically, rather than just a total cholesterol number. And increasingly more advanced markers like ApoB that some cardiologists consider a more precise measure of your actual risk. And a stress test, which evaluates how your heart performs under exertion and can reveal blockages that don't show up on a resting EKG. Stepping back, a heart attack is rarely a lightning bolt from a clear sky. It's typically the predictable result of years of quiet arterial damage, and it often gives real warning before the biggest event happens. You now know the 5 signs worth watching for: chest pressure or tightness, pain radiating to the arm, jaw, neck, or back, shortness of breath even without chest pain, nausea paired with cold sweats and lightheadedness, and the quieter, easy to miss presentation that shows up more often in women and people with diabetes. Any of these appearing for the first time is worth an urgent conversation with a doctor, and if it's happening right now, it's worth calling emergency services rather than waiting to see if it passes. If this made a serious topic a little easier to actually understand, subscribe and hit like. That's how more people find videos like this one. I'm Joshua Smith, and I'll see you in the next one.